This lecture is on training and certification in critical care ultrasound. I will refer to ultrasound as point-of-care ultrasound, bedside ultrasound, handheld ultrasound, and ultrasound in general interchangeably. I am Ziad Shaman. I am a pulmonary critical care physician at Metro Health, Case Western Reserve University, an associate professor, and the training program director for the Pulmonary and Critical Care Fellowship. I am also a registered diagnostic medical sonographer. The objective of this talk are three. First, to appreciate the advantages and limitations of the use of point-of-care ultrasonography. Believe it or not, there are limitations to the use of this technology. Second, to know that what you're in for as a learner and to list the expectations out of your training program. And finally, to position competency for you right between knowledge and practice. The Rational Clinical Examination is a series of articles published by JAMA. This series is one of my favorite. In it, many of our trusted clinical examination signs are described in terms of performance characteristics using sensitivities, specificities, and likelihood ratios. The series highlights the limitations of what we may take for granted, such as auscultating for carotid bruit, which has no utility in asymptomatic patients, palpating for AAA with a positive predictive value of less than 50% in aortas 3 centimeters or larger in diameter, percussion and vocal fremitus missing 20% of pleural effusions that are less than 300 cc's in volume, which is as bad as a chest X-ray. Unilateral RALs are falsely positive 25 to 40% of the time. And do you know that orthostatic hypotension as a sign of hypovolemia is not reliable, and that supine tachycardia is often absent in those with more than 1 liter blood loss, or that pitting edema is only reliably present after 10 liters of volume overload? Of course, it's not just the physical exam signs that are not perfect, but our practice environment is not perfect either. Sometimes our ICU rooms look similar to this makeshift ICU in the middle of a battlefield. Sometimes we are limited by the patient's body habitus, wound dressing, casts, tubes, and life support machines. And quite often we are limited by noise in the ICU, where it is usually the loudest part of the hospital. In comparison to a standard vacuum cleaner, a vacuum cleaner generates about 70 decibels of noise when operational. There enters the ultrasound machine. Those machines used to be slow, large, and clunky, but now are small, powerful, and user-friendly. They come with a promise of adding a useful amount of information to our clinical examination and hopefully offset the limitations of the environment and the limitations of the exam characteristics. There are, of course, many arguments for the use of ultrasound as an extension to the clinical examination. It is free to operate after the initial purchase or licensing and rental fee. Some tests are billable. It does not expose the patient to ionizing radiation and eliminates the transportation risk for patients, since the best place for a critically ill patient is in the ICU. The machine is generally available after hours, providing immediate results, and can be used multiple times per day or even multiple times per hour. And also, the information is available immediately, which helps guide procedures in real time. There are, of course, arguments against the use of point-of-care ultrasound. Here are some of the famous ones. I've done fine without it. The ABIM states that for eligibility for certification, practitioners are strongly recommended to use ultrasound to guide central line placement. Residency review committees suggest that thoracentesis and general abdominal and cardiac ultrasound exams are going to become requirements for training as well. I have done fine without it, may have worked in the past for those who are proficient at performing procedures without point-of-care ultrasound. The Joint Commission statement, however, on CLABSI prevention toolkit states that the central line insertion bundle should include ultrasound guidance. The Agency for Healthcare Research and Quality recommends the use of ultrasound guidance for central line placement and also the use of radiologic localization during invasive procedures such as thoracentesis. Plus, the worry about legal action was addressed in a national search for lawsuits filed against emergency physicians for the use of point-of-care emergency ultrasound over a period of 20 years ending in 2012. The report found no such cases. However, one case was filed for the failure to perform point-of-care ultrasound to diagnose an ectopic pregnancy before it ruptured. As trainees in a program under the ACGME, the rules are clear. Fellows must demonstrate competence in the use of ultrasound to perform thoracentesis and place intravascular and intracavitary tubes. Another argument against the use of ultrasound is, I tried it once but saw nothing. In his book, General Ultrasound in Critically Ill, Daniel Lichtenstein describes performing complete exams of the usual domains in critically ill patients and found that point-of-care ultrasound was able to provide some information 92% of the time, and that images were of optimal quality 77% of the time. Finding a hazy view instead of a pristine image on ultrasound seems to put some of us off, while a chest X-ray that is quite limited does not seem to damage our faith in frontal radiographs. This is an example. Two other arguments against the use of ultrasound is that learning it takes too long, and that no matter how much time one spends, they may never become as good as the experts to use it. Ample literature shows that learning point-of-care ultrasound starts right away. In this study, third and fourth year medical students significantly improved from baseline in image acquisition and interpretation after 45 minutes didactics and 45 minutes of scanning time. But I can't blame everybody. Even half of pulmonary and critical care training program directors in 2010 thought that learning cardiac ultrasound was too difficult to achieve during the 3 years of fellowship time. However, the learning curve is steep. For example, after an initial training session of 30 minutes didactics and 3 supervised cardiac exams, medical residents continue to improve at a rate of 27% in technique and 33% in interpretation for every 10 scans they performed. Consider the evaluation of B lines. It does not take much training to see that assessing B lines is accessible to almost anyone. In this study, after 20 minutes of training, the assessment of B lines was equally reliable in the hands of highly experienced echocardiologists using full feature platforms and in the hands of absolute beginners with miniaturized, compact, battery-equipped systems. For the arguments of, will I get as good as the experts? The question should really be, will I be able to do better than what I do now, which is depending on the difficult clinical exam? The answer was established a while ago and is published in the American Journal of Cardiology. Here, 61 patients underwent cardiac exams by medical students after going through 18 hours of training on the use of handheld ultrasound. Their findings were compared to technician-performed and cardiologist-interpreted echo exams. the students were able to accurately identify 75% of the abnormalities in valvular and non-valvular disease conditions. When board-certified cardiologists performed a clinical exam on the same patient without an echo, they were able to identify half of the abnormalities, which seems really good by itself, but in reality, I may prefer to have a medical student with a handheld machine examining my critically ill patient rather than a cardiologist without an ultrasound machine. As for forgetting what you learn, it happens all the time. Actually, you will likely forget most of this material because it's presented to you in lecture format, while it is much more likely for you to retain what you learn by doing. And learning by doing is the way we learn point-of-care ultrasound during a hands-on session. Vicky Noble in 2007 showed that without more training, emergency medicine residents' scores increased by 25% on image acquisition and on fast exam diagnoses after 6 months after the time of their initial training. As for losing clinical skills because of using point-of-care ultrasound, I would like to bring up what I call the navigator paradox. If you just want to go from home to work on a road that you have taken hundreds of times, then a navigator can be a distraction. But in a new city, without a navigator, you are limited in your ability to go around and explore without a navigator. Similarly, an anesthesiologist who has placed 100 arterial lines will probably be slowed down if using an ultrasound machine. But for someone who is still a learner, I'd say it's probably easier to learn a new procedure with the use of a visual aid. But not everything is nice and peachy with point-of-care ultrasound. There are actual limitations. Emergency medicine physicians' evaluation of ejection fraction at the mid-range of 35 to 55% suffers from poor agreement. Internists are worse than echo technicians in evaluating some areas of the heart, such as regional wall motion abnormalities, intracardiac thrombi, RV dysfunction, and pericardial effusions. And also, in abdominal ultrasound, diagnostic certainty only changed from low to high in 16% of the cases, while there was no change in the other 84% of the exam cases. This gives you a number needed to diagnose of 8, which is not terrible, but not great either. Therefore, there are many benefits to learning to use this technology and a few limitations, but the odds seem to favor this technology, while recognizing the limitations helps you get buy-in from stakeholders to achieve your goals as well. Switching gears now for some terminology definitions to distinguish competence from certification and from credentialing. Competence is the possession of required skill, knowledge, qualification, or capacity to perform a task. Certification is the process whereby an external agency, for example, the ABIM, recognizes competence in performing a task, while credentialing is the local hospital-based decision to grant the privilege to perform a task. For competence, in 2009, the ACCP issued a consensus statement with the SRLF on both the technical and the cognitive items that are needed for competence in performing several of the point-of-care ultrasound tasks, conveniently divided into domains. One example here is for pleural ultrasound. In the document, all of the domains of critical care ultrasound that were in use at the time of the statement are listed. An update for an additional couple of domains will probably be nice, but the document includes all that you will need for a head start in the field. There are 4 avenues for certification in point-of-care ultrasound, mostly through your training program, but also through external societies, board certification, or agencies. The most natural avenue for certification for a trainee is through your training program. If your program does not automatically grant you that recognition, start planning for it early. Speak with your program director and find out the necessary steps to get certified in the field before your graduation. If there are no set requirements, your program director will be very happy if you produce a set of learning objectives for yourself and for future trainees. This may be through elective time, course attendance, independent study, portfolio keeping, and/or scholarly activity. However, if you are out of training or if your program is unwilling to grant you certification, then you can look into one of the commercially available society certification processes. Here's an example of the ACCP requirements. They include online learning, attendance of 2 courses, an image portfolio, and an in-person assessment. This can become somewhat costly, but certainly doable in a year's time. Here is also the board certification pathways through the ABIM, but only in cardiac ultrasound and not in other domains. This includes more than just passing the National Board of Echocardiography exam. It requires a medical license, board certification in a specialty, a robust portfolio of comprehensive sets of images, and specialty training in critical care medicine. For those out of training, there is still a grandfathering pathway, which is set to expire in 2027, that adds CME requirements to the list. The QR code here points to the full list of requirements on the ABIM website, accessed June 2022. With exam material content listed here, the test is quite comprehensive, and it does take into account the integration of the cardiovascular system into the clinical status of patients in shock, respiratory failure, and trauma. The preparation for the exam is not something you can cram in a matter of a month or 2. So if you are thinking about taking the ABIM test for echo certification, plan for it. And finally, there are external agencies such as APCA, which is a subset of the American Registry for Diagnostic Medical Sonographers, established for doctors, nurses, and PAs that oversee point-of-care ultrasound certification. Their requirements include a medical degree, online learning modules, and a baseline exam in physics and instrumentation. Then, for each domain of certification, such as the ones listed here, there is an additional specialized online exam. Now for credentialing, which is just a politico-economical issue for each hospital and department. The American Medical Association states that privileging for ultrasound imaging should be a local issue to the hospital. Needless to say, there are no standards. So before you choose your future place of employment, you have to make sure of 2 things. First, that you get credentialed for the use of point-of-care ultrasound the way you want. And second, that you have control over a machine, because you don't want to find the promised machine locked up in a closet overnight or on weekends, or is occupied by other users when you need it most. And that brings me to the conclusion of the lecture. We discussed the advantages and the limitations of using point-of-care ultrasound in clinical practice and in education. We listed the requirements for training and credentialing, in addition to the pathways available for you for competency and certification so that you're able to practice point of care ultrasound. Thank you for spending time with me. I'm Ziad Shaman, and greetings from Cleveland.